Good evening, everybody. Thank you for joining us for medication management. My name is Mel and I'm a Sapien representative. Today I would like to present to you Ms. Jane Giles, who will be running this event. Just a couple of housekeeping items. If you require technical assistance with Zoom, please see the frequently asked questions link that's going to be in the Q&A feature. Microphones are on mute. However, please do submit your questions through the Q&A feature. The presenter will periodically stop to take questions. Please complete the evaluation form, which will pop up on your screens after the session, and certificates of attendance will be sent out electronically following tonight's presentation. We'd like to have an acknowledgement to country and acknowledge the Aboriginal and Torres Strait Islander people as the traditional owners of this country. We pay tribute to their physical and spiritual connection to the land, waters and community, enduring now as it has been throughout time. We pay respect to them, their culture, and to elders of the past and present. Next, I'd like to introduce our presenter tonight, Ms. Jane Giles. Jane is a clinical lead and advanced nurse consultant. For diabetes for the 6 regional local health networks. She has worked for Country Health South Australia Local Health Network since 1998 and in diabetes since 1992. Jane has a postgraduate certificate in diabetes education, a master's in advanced practice nursing, and a bachelor degree in education. She's been credentialed diabetes educator since 1999. Jane's primary focus is to clinically support and educate rural diabetes educators, as well as other health professionals such as GPs and allied health. The philosophy of the unit is to build the capacity of rural and remote services so that nursing specialist services such as diabetes can be provided as close to home as possible. I'd like to hand over to Jane now. Thank you.
Hi everyone, thank you for that lovely introduction and thank you all for joining the webinar tonight. I haven't actually done a webinar with this many people, so it's a bit of a learning curve for me as well as some of you, as I imagine. Tonight we're going to be talking about diabetes medications. And I know that it's a pretty hot topic. There are a lot of medications for people with diabetes now, and it can be quite a challenge getting your head around all of that. So I'll make a, do I need to click it, do I? Ah, there we go. Sorry, I have trouble with the PowerPoint. So what we hope to cover tonight is I'm going to take you back to a bit of Nursing 101. So we're just going to spend a few minutes talking about what is diabetes. I'm going to talk about type 2 diabetes and the diabetes pathway. So tonight really is a focus on type 2 diabetes. I'm going to talk a little bit about managing glycaemia and assessing glycaemia. We will spend quite a bit of time working our way through the medications that are currently available for type 2 diabetes. I want to spend a little bit of time talking about the education and self-management for people with diabetes, and then I've got some resources that we will demonstrate, and we do have some case studies, but we'll see how we go tonight because we haven't run these case studies using the webinar before. But we do have occasionally throughout the presentation we'll be asking some questions and getting you to answer them using an online poll. So the session's primarily for nurses working in general practice, and when we wrote this package we really had rural general practice nurses in mind. So I know that some of you out there are coming from other areas in health and maybe even from a metropolitan area. So if you just keep that in mind when we're going through the material, that it really does have a bit of a country focus. The other thing I wanted to really acknowledge at this point too is how important general practice nurses are to our system around educating and supporting people with diabetes. You guys play an extremely important role in all of this, and we value your input and the care that you provide to these people, and we want to be able to work as a bigger team of nurses for people with diabetes. With all learning, we do have some learning objectives. So again, I hope that at the end of this presentation that you will have a renewed understanding of the natural progression, the natural history of type 2 diabetes, that you'll have developed an appreciation of the range of type 2 diabetes medications. You're not going to walk away from this presentation as an expert in these medications, but if you appreciate the range of medications and have some sense of how these medications work and work alongside of each other, that's a huge step. And like all of us, we have resources that we go to when we need further detail. I'm going to spend a bit of time talking about the patient education needs, and I'm hoping that we'll be able to talk about referral pathways, and I'm expecting that that may come through some questions from you all. So you are able to ask questions as we go. You'll see on your screen that there is a spot where you can type in a question, and periodically I'm going to stop and have a look and see if there are any questions there for me to tackle. Okay. So, with the diabetes generally, and I think this is, understanding this aspect of diabetes is a little bit underrated. It is so important that you understand the difference between type 1 and type 2 diabetes. So when someone rings me and asks me for advice about a particular patient, and they will say, oh, you know, I've got Mrs. Brown and she's got diabetes, and she's not managing her diabetes very well, the first question I ask is, what type of diabetes does this person have? So it influences everything we do from that point onwards. So with type 1 diabetes, you will all remember from our Nursing 101 that it's an autoimmune disease, and the autoimmune response destroys the beta cells in the pancreas, and thus these people don't make any insulin, and it has to be replaced 24/7 with insulin injections or an insulin pump. With type 2 diabetes, it's a little less clear. So it's a combination of two things, of insulin resistance and reducing insulin capacity. And I think people forget that with type 2 diabetes, people progressively lose their capacity to make insulin. And then they simply can't make enough insulin to overcome the resistance, and hence their blood glucose rises. So this slide is a little bit complex, but I just want you to focus on two lines in this slide. The top red line is the one, insulin resistance. So you can see that the insulin resistance rises even before the diagnosis of type 2 diabetes is made. And this can happen for a range of reasons. It can happen because the person's getting older. So we know older people have a change in their muscle fat ratio. They might stay the same weight, but their muscle fat ratio changes. It normally happens with age. It can happen with people who gain weight around their middle. So central obesity will increase insulin resistance. Inactivity will increase insulin resistance. And certain cultures are more prone to developing insulin resistance, such as Aboriginal and Torres Strait Islanders, Pacific Islanders, some Southeast Asian cultures have a propensity to develop insulin resistance. So you can see if you are resistant to your insulin, then you're going to need more insulin to do the same job. So at the same time, if you have a look at the top yellow line, that's your endogenous insulin. So as your insulin resistance increases, people do make more insulin to overcome that resistance. But over time, people's capacity to make insulin declines quite dramatically. So we see from the research studies show us that around about 50% of people with type 2 diabetes, by the time they get to about year 7, 50% will need to be on insulin to keep their blood glucose under control. So if you think of all the people with type 2 diabetes in your practice, in your area, and the number of them that are on insulin, you might get a sense that there are a number of people that probably should be on insulin that aren't on it for various reasons. So I'm hoping that starts to give you a bit of a bigger picture about this type 2 diabetes problem. So we're going to stop there and run a little poll before we move to the next. While you're doing the poll, I'm just going to have a look and see if we've got any questions. Okay, so type 2 diabetes is caused by okay. Sometimes finding the poll for the very first time can be a bit tricky.
So to the attendees, we'll just leave the poll open for another 10 seconds, just so everybody has an opportunity to answer. We'll end the polling there. Thank you.
Okay, great. Thanks, guys. That's excellent. Okay, so yeah, no, that's good. Excellent. So moving on to the next slide. There we go. So when we think about glucose monitoring, HbA1c has been really the gold standard, if I can use that word, for many, many years. So predominantly the research that's done around diabetes, whether it's type 1, type 2, usually they are looking at diabetes control based on a HbA1c reading or target range. This little resource, I think, is quite a useful one in education. I love the way it goes from green to yellow to red, because everyone, unless you're colourblind, everyone can get that sense of, you know, it's okay, it's sort of not too bad, and now it's getting where I should be really worried. So we use these sorts of resources when we're explaining HbA1c to patients. And I think those visual resources are really useful in helping people understand what these readings mean, what these tests tell us about how they're tracking with their diabetes. But HbA1c just on its own really doesn't tell us what's under the blanket. So you get this overarching reading, which might tell you that this person is, on the face of it, tracking quite well. But when you lift the lid and you look at blood glucose monitoring, you might find other problems happening. So you might find someone who is swinging from hypos to hypers to hypos, and although their HbA1c looks pretty okay, they are feeling terrible. People do not do well when blood glucose bounces around like that. It makes them feel very tired. They can feel quite irritable. They can feel quite overwhelmed by their diabetes. So looking at both HbA1c and someone's blood glucose monitoring results is a really important thing to do, because it does tell you a different story. So there's been a fair bit of conversation about, well, who should be blood glucose monitoring and who doesn't need to. And we've started to fall into a bit of a trap where people who aren't on insulin may not be educated in the value of blood glucose monitoring and the options around blood glucose monitoring that they should. But NDSS and the RACGP make it pretty clear the sorts of patients that are important to teach blood glucose monitoring to. So for patients on insulin, obviously, if they're on glucose lowering agents that can cause hypoglycemia, so insulin obviously can cause hypos, but the sulfonylureas can cause hypoglycemia as well, and that's an oral medication. When someone's unwell, and everyone with type 2 diabetes is at risk of becoming unwell. So teaching blood glucose monitoring and where blood glucose monitoring can help patients, clearly you can see if someone's sick, they often spike high blood glucose readings. So if they're not blood glucose monitoring, if they haven't got a meter at home and they haven't got in-date strips and they can't test when they're sick, they don't know if their blood glucose is going out of control. So blood glucose monitoring is a core component of someone's sick day action plan. Obviously with pregnancy and pre-pregnancy planning, so we are seeing an increasing number of women with type 2 diabetes who are in childbearing age. So it's important to think about pregnancy and pre-pregnancy, even though traditionally people with type 2 diabetes may have been older people. The trend and the profile of people with type 2 diabetes is certainly changing. When you're changing treatment, so the GP might be moving someone from one single medication to a second medication because their HbA1c is high. Using a home blood glucose monitoring in situations like that will help titrate the medication and get someone back to target quicker than getting them back in 3 months and checking their HbA1c again and seeing that it hasn't made very much difference. That's been a whole 3 months that person has been experiencing hyperglycemia that they probably didn't need to if we had done home blood glucose monitoring and been able to assess the blood glucose more quickly. Sometimes if a patient might have a particular type of anemia, we see sometimes with a hemolytic anemia that the correlation between the HbA1c and the blood glucose readings is not reliable. And so we have to use home blood glucose monitoring to be able to assess people in those situations. So you can see that there's some very good reasons to be talking to patients about home blood glucose monitoring and when to do it to get the best value out of it for their health. This is just a snapshot of the NDSS page. So I would encourage you, if you're working frequently with patients with diabetes in your general practice, this would be a good page to bookmark because if you don't have good access to a credentialed diabetes educator, the GP is the only other person who can sign their NDSS registration form. So printing these off, having them handy, ready for the GP to sign, is a great way to be able to support people with diabetes to get registered on the NDSS, even if they're not starting home blood glucose monitoring straight away. The NDSS register, so the list of patients that are registered with the NDSS, is a database that the government used to monitor the number of people with diabetes in Australia. So if you've got people who aren't registered because they're not home blood glucose monitoring, they still need to be registered. We still encourage people to be registered because those numbers aren't then coming up on the national database, and the government basically doesn't know that those people are out there. So before we move on to medications, what slide are we up to? Okay, so we will do a little bit of the medications. I'm just going to see if there's any questions. It's a bit tricky this end. No? Okay, so we're all good so far with questions. People are happy so far. All right, so let's make a start on these. Yep. So the RACGP, which is a document or a booklet that all of you guys working in general practice should be very familiar with. It's a fantastic little resource and it provides a lot of really good information about managing type 2 diabetes. So the RACGP says that the choice, order and combination of medications used are based on evidence of improved clinical outcomes. So obviously all of these medications have gone through clinical trials and been approved for use in Australia. But we need to make sure we're thinking about the risk of side effects and obviously patient choice and their capacity to manage these medications. Now, there are algorithms that have been designed to help navigate these choices, and the Australian Diabetes Society has developed one that I quite like, and I've got an image of it coming up, I think. It's well worth keeping that image handy because not only does it help guide the stepping through the medications, it's also not a bad way to explain to people that there are a whole bunch of medications that can be chosen for a particular person's type 2 diabetes. And really, it's about matching that medication to that person the best we can. One of the things that I just quickly say at this point is that at every step of the way, whenever we're assessing someone's diabetes and thinking about moving someone on to the next step, an additional medication, I always take the opportunity to go back and just revisit the SNAP behaviour risk factors. So just revisiting smoking, nutrition, alcohol and physical activity. And all of those things, improvements in all of those things underpin any medication that's prescribed. So this is the Australian Diabetes Society resource that all of the general practitioners have access to. And you have this as a handout. And I think it's a fantastic resource to really start to get your head around the different medications and how you might step through the first medication, then adding a next one and then adding a next one. On the back of this, no, that's not on the back. On the back of it, unfortunately, I don't have a slide of that, but if you've printed it out, you've got it handy, you can just flip it over and you will see where it's been grouped by the different family of medications, and there are some examples there of trade names to help you make the connection between the generic name and the trade names, because there are a lot of different companies making a whole range of diabetes medications now. This slide we've put in just to give you a sense of the sort of things that are reviewed and tested with the medication. So with any diabetes medication in research in Australia now, they have to have a cardiovascular event outcome. So they have to measure that. They can't not measure that. They can't just measure blood glucose. So there are various medications that have greater cardiovascular protection. Some have more renal protection than others. And all of these things are taken into consideration when the GP is choosing a medication. And as nurses, for us, working alongside of the doctors that prescribe these medications, if we understand some of this stuff, we're able to educate the patients about what are the benefits, what are the concerns, what are the things they need to look out for. So that's a really important role for us as nurses, to support patients so that they understand these medications and why they might be prescribed a particular medication above something else. So this slide, I've used this slide for what feels like 100 years. And when I first started using it, I only had about 4 boxes on it. And how you can see that I can barely fit another one in. So I don't know what's going to happen if they come up with a new medication. But I've used this little picture for a long time for both patient education and for health professional education. For patients, I think it's quite good to be able to help explain why you might end up on 2 or even 3 different medications for your diabetes. So it gives an opportunity to explain that different medications work on different aspects of the pathway. And so they can see quite easily then that, oh yeah, the 2 medications aren't doing the same thing. They're doing separate things, working alongside of each other. I've used this image a lot with Aboriginal health workers, and they have found it quite useful in explaining medications to their client group as well. So what I'm going to do in a minute is I'm going to take each one of these groups and we'll work through them and talk about them in a little more detail. But before we move on, there is another poll, and the question is, all diabetes medications can cause hypoglycemia. So let's see what you guys' thoughts are.
So everybody, I'll just give you a minute to answer the polling, and then we can share the results with Jane.
While you're doing that, I'll just see if there's any questions. No. Oh, is that a question? No. Oh, no.
Now, Deb, we've just noticed that you've answered the polling in the Q&A function. If you could just answer the polling through the main screen, the pop-up that appears on the main screen, that would be fantastic. Thank you. And if anybody has any questions, please do feel free to type them in the Q&A function for Jane. Jane is more than happy to take any questions. Thank you, everybody. We'll just send the poll in here and share the results.
So we've had a question from Helen about where the poll is. It looks like some are having difficulty finding the poll on the page.
All right. Helen, so the poll will appear on the screen. If I can type to you separately, and we can work through some troubleshooting, because it appears as though it's not actually popping up on your screen. So I will message you separately to this. Thank you. There's the poll results.
Okay. All right. Now, okay, so that's really interesting, guys, the results we've got from that poll. So 69% said no, not all diabetes medications can cause hypoglycemia. But there were 31%, so 11 of you, who said yes. So let's see what the next few slides tell us, and we'll see if we can change the minds of the 11 that said yes, all medications cause hypoglycemia. All right. So now this next section is a bit repetitive. There's a lot of information on the slides. I'm not going to read everything from the slides because we will send you the PowerPoint and you will be able to have these slides as a reference tool. So don't feel like you need to write down lots of notes. Just sit back, relax, and try and just take it in. So Metformin, all of you will be very familiar with Metformin. Metformin we've had in the system for a very long time, and it continues to be the first line of choice of medication for people with type 2 diabetes. And as you can see, there are quite a few different companies that make Metformin. And I guess one of the things that I really want to highlight at this point is that when you're talking about medicines with people and you have an opportunity to have their medication box to use as a tool, or you have a empty medication box in your little kit of education resources, please talk to them about the trade name and the chemical name, because lots of people get confused over this, because Metformin is the chemical name for all of those brands, but all of those brands will have a different brand name up there. So that particular box has diformin, but it could be any one of those other ones below. So you can see if people only look at the trade name and they don't learn the generic or chemical name, then potentially you can have people doubling up on the same medication. It just has two different trade names, and I still see that from time to time. So it's important as nurses for us to be really conscious of that and try and pick it up where we can. So with Metformin, Metformin is a terrific medication for helping reduce insulin resistance. And how it does that is that it makes the peripheries more sensitive to insulin and the liver more sensitive to insulin. So one of the problems that people with type 2 diabetes get due to insulin resistance is they get this overproduction of glucose overnight. So I would imagine quite a few of you would be familiar with what I'm about to say. You get Mrs. Brown who comes in and she either talks to you or she shows you the glucose record book, and she's always high in the morning. She's always 10, 12, 11, 9, 15, 10. She's just constantly high in the morning. But over the course of the day, you notice that her blood glucose seems to go down a little bit. And she tells you, but I'm not eating very much at tea, I don't have a snack, I don't know why my blood glucose is high in the morning. The problem is that her liver is overproducing glucose overnight because it's resistant to the insulin, and the insulin controls the amount of glucose that's put out by the liver. So the insulin's not turning off the output from the liver when the blood glucose rises. So you just get this continual glucose being released by the liver. Metformin is a terrific medication for that, but if you're thinking about lifestyle stuff that might help alongside of metformin, certainly exercise will absolutely help with insulin resistance. And I've seen some quite nice results from people who take a walk after their evening meal. So if it's safe to do so, obviously, having an evening walk or a walk before tea when it's still light, I've seen some nice results with some people around that. But metformin is a very safe medication to take, and it's been in our system for a long time. You do have to be a bit careful with renal and hepatic impairment. So the renal function needs to decline quite low before the doctor will start cutting back the dose. So you're looking at EGFRs of less than 30, cutting back the dose quite significantly, and generally by the time it gets to about 20 or they will cease the metformin. So people need to be aware of their renal function. I always tell my patients what their EGFR is, and so that they can track it, and that they are aware that metformin needs to be titrated down as their renal function declines. We still cease it before surgery. So if you've got patients that are planning some kind of surgical procedure, even just fairly minor procedures, we still cease metformin the day before surgery, and then it can be restarted once the person is eating and drinking normally afterwards. In elderly and in pregnancy, we use it with caution. So in pregnancy, we do see it used with gestational diabetes. In elderly people, particularly because of their renal function, we're a bit careful. There are some side effects. So common are the gastrointestinal side effects. Vomiting, anorexia, pretty rare. Mostly what people have is a bloating. They will feel nauseated. They might get diarrhea. So diarrhea is more common than vomiting and anorexia, but their loss of appetite, generally, if the nausea is quite bad, that will affect their appetite. So asking people about their symptoms is really important, because what people do is they stop taking the medication. They get side effects and then they stop taking it. So if we preempt people with it, with the knowledge about what are the potential side effects, if they do develop side effects, they will contact you or contact the GP, and the GP can either re-prescribe a lower dose, or even cease it depending on the intensity of the side effects. So the practice points really are to start low and go slow, particularly if someone's got a history of a funny, what we would call a funny gut. So if they have any issues around that, just take it slow. Check the renal function obviously before starting, and if the person is having their diabetes cycle of care, you will have access to their renal function. Blood glucose monitoring, potentially if you're switching from we've written here standard tablets, that's actually not quite right. That should read, so the standard tablets as compared to the extended release. So you might see a bit of changes in blood glucose if you're just switching people from the normal metformin to the extended release. So a little bit of blood glucose monitoring there doesn't go astray. So that's metformin. So the next medication we've got on the list is the sulfonylurea group. Oh, gosh, Jane, I totally forgot to say, metformin does not cause hypoglycemia, okay? It doesn't make extra insulin, so it doesn't cause hypoglycemia. All it's doing really is making the insulin that the person is making work a bit better. So the person can still shut down their insulin production, no problem. So if their blood glucose does start to fall for any particular reason, their body naturally just turns down their insulin production. So there's no risk of hypoglycemia if they're just taking metformin. The sulfonylureas have been very, very common over the years, but they're starting to lose their attraction because we've got other medications that are available to us now that seem to be able to fill that gap. So again, you can see that there's a trade name and there's a generic name or chemical name. Sometimes I'll use the word chemical name for patients. And so you can see that unless the person is familiar with their chemical name of their medications, they could fall into the trap of getting two different prescriptions, same drug, different trade name, and double up. So with the sulfonylurea, it increases the pancreatic insulin production. So it kind of kickstarts the beta cells to make more insulin. So because of this, hypoglycemia is an adverse event. So the people that are on a sulfonylurea absolutely have to have a hypo action plan. If there's been a past history of ketoacidosis, it needs to be used in care. We don't use it in type 1 diabetes. We don't use it in acute illnesses, and they do need to be careful when there's renal or hepatic impairment, and certainly around surgery. It's not approved for children, and we don't use it in pregnancy or in breastfeeding. Hypoglycemia, as I said, is the most concerning adverse event, and we see that more increased in older people, people with renal or hepatic impairment. And one of the other things that really does bother people is that it can cause weight gain. So as it brings the blood glucose down, sometimes people feel symptoms of hypoglycemia at slightly more elevated levels than what we would normally treat hypo. So traditionally we would treat a hypo at less than 4, but if someone's been high for a while, they might feel a bit funny at around 5.5 or 5. When people feel those symptoms, one of the normal body reactions is that they feel hungry, and so they tend to eat more. So it's something that you need to talk to your patients about. If they're on a sulfonylurea, you need to warn them that this might happen so that they can counteract that hunger urge by either distracting or choosing foods that are low in caloric value so that the weight gain is limited as much as possible. Because obviously if people with type 2 diabetes put on more weight, that's going to affect their insulin resistance and make it harder to control their diabetes. Again, we start low and increase slowly. We don't want to give people a big dose of this and cause them to have a nasty hypo. Swapping between different brands of sulfonylureas doesn't really make any difference. So it is something that we've seen happen, but it doesn't help. If they're not controlling their blood glucose with one particular brand, swapping to another brand's not going to make any difference And I've put in here refer to a CDE for hypoglycemia action plan. There aren't CDEs everywhere, and so there are diabetes educators that are registered nurses that can help put these together. They can be fairly straightforward, or they can be tricky. So even picking up the phone and having a chat to the diabetes educator that you have in your area about whether this would be an appropriate referral would be a great thing to do. And then the diabetes educator can talk you through it on the phone if it's someone who's fairly straightforward and you feel like you might be able to do it. So the next medication group are what we lovingly refer to as the DPP4s. Now, these aren't new anymore. They've been around for a little while. And I'm still in awe of this medication. There's a hormone in our gut that we make called GLP-1. And when we make that hormone, it can stimulate the production of insulin. But it only does that when there's carbohydrate in the gut. So if you've eaten a meal containing some carbohydrate, we normally produce this hormone, and then that gets the insulin being secreted. And of course, then the insulin deals with the carbohydrate that's coming from the food, the glucose that's coming from the carbohydrate. So it's really, really a clever hormone. Like I said, I'm in awe of this little hormone. What they discovered is that in people with type 2 diabetes, their response, so how quickly they make this hormone when they eat carbohydrate, is delayed, and they don't make very much of it compared to someone of a relatively similar age or weight, health condition, who doesn't have type 2 diabetes. So some bright scientist somewhere has been able to develop this medication that stops the destruction of GLP-1 in the gut. So it doesn't last very long, and this medication helps what the person's making themselves last a bit longer to try and get a greater effect from the GLP-1 hormone that they're making themselves. The really amazing thing about this is that even though they take a tablet, it still only works if the person has eaten a carbohydrate-containing meal. So that means it's safe from a hypoglycemia perspective. So it doesn't make the person hypoglycemic. So for example, if the person just had a piece of steak, they had some lettuce, tomato, cucumber, and didn't have any potato, didn't have any rice, didn't have any bread, so there's virtually no carbohydrate in that meal, they still take their medication, but the GLP-1 destruction isn't affected. It goes away quickly. So you don't experience hypoglycemia. And so it's a really safe medication for people who, if they were to be at risk of hypoglycemia, would cause a big disruption to their life. So we're seeing a lot of people taking this medication, being prescribed this medication. So it increases the concentration of GLP-1, and it's glucose dependent. And so that means that it's only activated if there's carbohydrate in the gut, if the person has eaten a carbohydrate-containing meal. However, if it's used alongside of a sulfonylurea or insulin, it can increase the risk of hypoglycemia. So it might double up. So again, for nurses working with people with diabetes who are being prescribed these medications by GPs, It's so important for you to be able to understand this stuff so that you can give people the right advice about how to self-manage. Interactions with ACE inhibitors have been noted. So if anyone has any angioedema, then it would be used very cautiously. We don't use it in pregnancy or in breastfeeding. So adverse event, only hypoglycemia if it's used alongside of insulin and sulfonylurea. But if it's just used with metformin, then you won't see that hypoglycemia. There have been some headaches noted and some musculoskeletal pain noted. So the practice points around the DPP4 inhibitors is that it needs to be an assessment by the GP about the risk of pancreatitis. So it has been known to trigger pancreatitis in patients who have previously had pancreatitis, but it is quite low, but it is something that you need to be aware of. The DPP4s don't seem to have any significant effect on weight, either increasing weight or losing weight. So I'm going to stop there. We've got another poll before we move on. So the question is, only people with type 1 diabetes get diabetic ketoacidosis, yes or no?
So everybody, once again, we'll just give you a moment to answer that. And while we wait, there's a few questions and answers for Jane.
Okay, so okay, so Marion has asked, while you're doing the poll, Marion has asked, so if metformin is causing an issue with renal function, what other medications could the GP offer? So just to be clear, metformin doesn't cause issues with renal function, so it won't cause renal function to deteriorate or renal impairment. But it has to be used cautiously in patients who already have renal impairment. So if you think about medication like metformin being cleared by the kidneys, if renal impairment is impaired, the medication isn't being cleared by the kidneys as well as if they had a good renal function. And so there is a risk of that medication building up to a toxic level. And most of you would have heard of conditions where metformin has caused problems. And so I think you have to be really clear with your patients. It doesn't cause renal impairment, but we need to use it cautiously with patients who have renal impairment. The other question, Atlantis production is going to cease. Okay, so there's Monica has asked a question about Lantus, insulin Lantus production going to cease and be replaced by new insulin. So we have an insulin section in the PowerPoint that I will talk to that when we get to that point, Monica, but that's a really good question. Thank you. Both of those questions were excellent questions and really appreciate that.
And so, ladies and gentlemen, we'll just send the polling there and share the results.
Okay, so okay, so just a little just a feedback on that. So 32% think that only people with type 1 diabetes get diabetic ketoacidosis, and 68% said no. So that 68% must think that there are some other groups of people with diabetes who might become acidotic. So it'll become a bit clearer as we go into the next slide why I've asked that question. Oh, I keep forgetting to click on the screen. Okay, so the other kind of new medication to the game is the SGLT2. And the SGLT2 medication, like with all the others, is made by a few different brands. So again, I know I keep sort of saying this, but I think it's so important for us to talk about these medications in the context of their trade name and their chemical or generic name with our patients, so that they understand that. So the SGLT2 medication, how that helps the person's blood glucose is it reduces the glucose reabsorption in the kidneys. So you know how we so with the way the kidneys work is that the body basically pushes as much out as possible and then reabsorbs in the distal tubules, reabsorbs back what the body wants to keep. So with this medication, what it's doing is it's blocking the reabsorption of glucose in the kidney, so the person will wee out the excess glucose. So these are patients that will pretty well always show glucose if you did a urine dipstick. I know it sounds a bit crazy, but it works really, really well. Those patients that respond to this do very, very well. So on its own, or if it's used with Metformin, for example, it won't cause hypoglycemia. But again, if it's used alongside of the sulfonylurea or insulin, then of course there is the risk of hypoglycemia. With this medication, we do have to be really careful with the sick day action plans that we do for patients, because with acute illness, prolonged fasting, low carbohydrate intake, so if someone's off their food, if there's excessive alcohol intake, these patients, even though they have type 2 diabetes, are at risk of ketoacidosis. So what we're seeing is something called euglycemic DKA in these patients with type 2 diabetes. So it's an acidosis, ketoacidosis, that's occurring at a near normal blood glucose reading. So if you think back to your hospital days when someone with diabetes, say type 1 diabetes, would come into hospital and they'd have a blood glucose of 28. You check their ketones and they've got ketones of 2.5. 3. You do their blood gases and they're acidotic. So often high blood glucose goes alongside of diabetic ketoacidosis. But interestingly enough, in these situations, someone with type 2 diabetes on an SGLT2, they might present with a blood glucose of 10 or 9, and they can still be acidotic. So one of the education points for patients on this medication is if you become unwell, you get a nasty cold or you get the flu, you have to fast for a procedure, you go off your food and you're not eating very much, or you've had an alcohol binge, even though your blood glucose is relatively normal, you need to get your ketones checked. Now, I'm not sure how many general practice surgeries out there have the capacity to check ketones, but I think that now that we have this medication on the market and that people are at risk of developing ketones and progressing to diabetic ketoacidosis, that it would be really worthwhile you going back to your practices and having the conversation about the capacity to test for ketones. And I'm not talking about urine ketones, I'm talking about blood ketones. So that's a point of care test, a finger prick on a little meter. The other thing that can be a bit of a problem is if people get dehydrated. And we have seen also some issues around some urinary tract infections for some people who might be prone to them or have difficulties with hygiene. So if you imagine that the person's urine is got quite a bit of glucose in it, you can imagine that if hygiene was an issue or someone already had a history of repeat urinary tract infections, that this medication might not be a terrific choice for them. Again, with most of these medications, being aware of people's renal function. If they are going for surgery, this medication needs to be stopped 3 days before they start fasting. In elderly, again, because the assumption is that renal function is often declining, pregnancy we don't use it, and don't use it in breastfeeding. So the adverse events, as I've said, genital infections, urinary tract infections are the most common. Hypoglycemia only if used with sulfonylurea or insulin. Can get some constipation. I've not seen much of that. Have seen some nausea and need to, again, be very careful with renal function. The euglycemic ketoacidosis, although it says it's infrequent and rare, it is very severe when it occurs. And so we all have to be really diligent about talking to our patients and reminding them that if they become unwell, they need to have their ketones checked. And they can either, if you've got that capacity in your general practice to be able to do that in the same way that you do a blood glucose finger prick check, you can do a ketone finger prick check. If you don't, then obviously they need to present to a hospital. So the sick day and the hyperglycemia action plans are very important for these people because they need really clear advice about how to manage these medications when they're unwell. There is a little patient education fact sheet that we produced together with the Royal Adelaide Hospital, and you should have a copy of this as part of the material that was sent out to you, but this also sits on our website with all the other patient education material. And the very last slide that of this PowerPoint, there's a web address, so you're all very welcome to access the resources on that website if they can help you with your patients. The GLP-1 agonist is like the brother or sister to the DPP-4. So this one is not a tablet, it's a subcutaneous injection, and it is injecting the actual GLP hormone into the person. So there are 3 different brands, or 2 brands and 3 different types on the market at the moment, and this medication is proving to be quite acceptable by people with type 2 diabetes, particularly the one that's a weekly injection. So there are 2 weekly injection options with this medication, and we're seeing some really good results with this. But it is an injection, so the person needs to be prepared to self-inject. So again, this hormone stimulates the production of insulin when there is carbohydrate in the gut, which again makes it quite a nice medication for people, because on its own or without a sulfonylurea or insulin, it does not cause hypoglycemia. You have to be careful with severe gastrointestinal disease. So the quite significant gastrointestinal disease like gastroparesis or dumping syndrome. History of pancreatitis, again, be cautious with gallbladder disease. They have seen some suggestion in the research that it may increase the risk of gallbladder disease. We don't use it in pregnancy and in breastfeeding. It's common enough, the nausea and the vomiting. With mild nausea, that seems to settle fairly quickly. But for those people who do vomit, it can be very distressing, as you can imagine, and so we are having to cease it in some patients. More severe adverse events that have been seen have been pancreatitis. There have been some allergic reactions, but these have been quite rare. They have noted in some studies that there has been onset of acute renal failure and worsening of their renal function, their chronic renal failure. So in those patients, obviously, if there's already some suggestion of renal impairment, then it's not a good medication to use. And of course, your GPs will be doing these assessments of these patients and making sure that they're safe to be prescribed. We're on the home run with these, and these last two medications we'll talk about fairly quickly, because we're really not seeing them used anymore, but they still are around in our system. So I just wanted to let you know about them. So Acarbose, there's only one company that makes that in Australia. It delays the absorption of carbohydrate in the small intestine. So what it's doing is it's pushing the carbohydrate further down the gut before it starts to be sort of broken down and absorbed. And the effect that that has on blood glucose is that it delays and slows the glucose entering the bloodstream. So you see less of a peak in someone's blood glucose. On its own, it doesn't cause hypoglycemia, but obviously if it's used in combination with sulfonylurea or insulin, there is a hypo risk. It's contraindicated in people who have had GI problems, things like bowel obstruction, inflammatory bowel disease, GI disorders like malabsorption. You would not prescribe this medication for these people. Again, renal impairment, don't use it in pregnancy or breastfeeding. It's got a really embarrassing side effect because it makes people fart a lot. And in Australia, people find that really distressing, especially in older people who already might have a bit of a problem with a bit of wind getting away from them. It's terribly embarrassing for people. So most people hate this medication. Once they start to get some side effects, they just stop taking it because they just can't cope with the side effect. Some people do get some abdominal pain and distension, so they're getting extra wind in their gut. There are a list of more infrequent and rare adverse events, but really we won't spend any time on those because the likelihood of you seeing this medication is pretty low. If someone is on this medication and they are taking insulin, for example, they need to have a very clear instruction around their hypoaction plan, because if their hypoaction plan, their first step, so their quick acting sugar, is sucrose, it won't work, because this medication blocks the absorption of sucrose in the gut. So these people must have a glucose containing first step in their hypoaction plan. So Coke won't do it, lemonade won't do it, sugar won't do it, honey won't do it. All of the sugars in those products will all be blocked and delayed in the absorption. So they need to have either a glucose drink, so something like Glycated, or glucose jelly beans, and the proper glucose jelly beans, not the ones from the supermarket, but the proper glucose ones from the pharmacy. Otherwise, they will not, they won't get any response from their treatment. If they overeat carbohydrate, this medication sort of amplifies, if that's the right word, the gastrointestinal side effects. So it will make their flatulence, their diarrhea, their abdominal pain, their distension, it'll make it even worse. Starting low and titrating slowly had been our way of approaching this drug, but really it didn't. It just didn't help. It was just one of those odd things about the culture in Australia. People just couldn't cope with it. So the very last specific medication of this group is the glitazones. Now, again, we see these very rarely, and as far as I understand now, they are only available on a special script. So we will see less and less of these used. But, when they were first released, we didn't have the DPP-4, we didn't have the GLP-1, we didn't have the SGLT2. And so this medication was used quite a bit to overcome insulin resistance. And so in some ways it worked a little bit like Metformin, but its pathway was different, which caused some issues. So really, heart failure patients, I have to say, were the biggest risk group taking this. We saw increased peripheral edema, weight gain, some other side effects or adverse events were around headaches and dizziness, so it weren't pleasant for people. More infrequent events were an increase in fractures, which obviously in older people is not a great thing. Progressing heart failure, pulmonary edema, macular edema. So there were a bunch of nasty things that were happening to people. So whenever this medication is prescribed, it's a really thorough assessment of the risk of fluid retention for a particular patient, and certainly if there's any sign of heart failure, it's well and truly contraindicated. They saw in the research some signs of increased risk of heart failure when it was combined with insulin, but I can't explain to you the reason for that. I don't know the detail of that, only that it popped up in some of the research studies that that combination wasn't great for heart failure. But again, I don't think you're going to see this medication. The ones we've talked about initially are the ones you're going to be seeing. So I'm going to stop there. So after we talked about the SGLT2, I hope that I've convinced you that diabetic ketoacidosis does not only happen in people with type 1 diabetes, that there are situations for certain people with type 2 diabetes where diabetic ketoacidosis can occur. And if you know that and they turn up at your practice, you will know straight away to check their ketones. because if you pick up progressing ketones early enough, you will actually prevent diabetic ketoacidosis if the person can get to hospital and have extra insulin. So we've got another poll, and the question is, I feel confident in explaining the different types of insulin to my patients, yes or no?
So I'll just give everybody a minute again to answer that, and while we do so, Jane will have an opportunity to answer any questions. So please feel free to keep sending them through the Q&A function.
Okay, so Marion has asked a really intriguing question. If a person doesn't have a gallbladder, would this GLP-1 agent be avoided? I actually can't honestly answer that with confidence. I could take a guess and say that if the person doesn't have a gallbladder, then I don't think it would be a problem. However, I'm not confident in that answer. So what I'd like to be able to do, Marion, is if at the end of this presentation you will find an email address on the very last or second to last slide. If you were happy to email me that question, what I'll do is I will check with one of my friendly neighbourhood endocrinologists and get that answer back to you. But that's a really good question because a lot of people don't have their gallbladder.
We'll just give everybody another moment just to finish the polling. Ladies and gentlemen, we'll just send polling there and share the results.
Okay, so all right, so this is, thank you for being so honest with this one. So we've got about 30% that feel confident, so that's fantastic. So hopefully you might pick up maybe something new from the next few slides, but there's 70% of you. There's 70% of you who have said that you don't feel confident in talking about insulin or explaining insulin to your patients, and that's not unusual. Particularly in the last few years, there's been an influx of many different insulins, and a lot of the approach to insulin has changed somewhat, and so the fact that you don't feel very confident in talking about insulin is not surprising. You guys see everyone with everything, and diabetes is just one part of the health kind of spectrum that you all have to deal with. So I'm hoping that the next few slides will give you a resource that you can refer to when you need to talk to people about their insulin, so that you feel a little bit more confident in doing so. So insulin, it basically replaces the insulin that the person is not making themselves. So in type 2 diabetes, often when I talk about insulin with patients, I say put it in the context of things like, you're just not making enough of your own anymore and this is going to top you up. so that you've got enough insulin on board to be able to deal with the glucose. So in type 2 diabetes, it's very much supplementing what people can't make themselves. Care when there's trauma or illness. You will all know that if someone is unwell and they have diabetes and they're already on insulin, they most likely need more insulin when they are unwell. And the stress hormones that we make, cortisol, adrenaline, noradrenaline, all contribute to insulin resistance. And so when the body's under stress, whether it's from trauma or from illness or infection, those stress hormones are released and insulin resistance climbs, and immediately people need more medication than they normally do. Insulin obviously needs to be considered when patients are having surgery. So how's the insulin going to be managed in the surgical or perioperative environment? We do have to be careful in pregnancy and breastfeeding, and the reason around that is that in pregnancy and breastfeeding, blood glucose can change dramatically and quickly. And so extra care with insulin, education around insulin with pregnancy and breastfeeding is really important. Adverse events, of course, hypoglycemia. So we've talked about the sulfonylureas, now we're talking about insulin. So these are the two medications that will cause hypoglycemia. All of those other medications will not cause hypoglycemia on their own. It'll only occur if they're in combination with a sulfonylurea or insulin. Weight gain can be a problem with insulin for a very similar reason to the sulfonylureas. So if someone has been relatively high with their blood glucose, you know, even just into double numbers, and then we're saying, oh, well, you know, 6 to 8 is a better place for you to be, rather than, you know, 10 to 15, they may feel hunger as their blood glucose starts to dip, and so there's potential to eat more. So let's not forget that that insulin is basically a growth hormone, and so it will make you hungry. If you've got insulin, lots of insulin on board, you will feel hungry. So people need to know, they need to be able to preempt that, so that they can use strategies to limit their overeating and maybe to choose foods that aren't as high in calories. Because certainly when people feel that urge to eat, when they are taking insulin, they have a propensity to binge. So education and support of people is terribly important, and you guys are perfectly placed to be able to provide that. The practice points, we are now seeing some high-strength insulin being used quite commonly in the Australian market. So there is an insulin glargine, which is 300 units per mil, and we've all grown up with the 100 units per mil formula in Australia. So this is 3 times the strength in this, and so you have less volume. So there are some changes there. With type 2 diabetes, a lot of the other medications can stay on board. Some of them can't, but most of them can stay on board with insulin. We tend to always keep metformin as long as the person's renal function is maintained. But if they're on sulfonylurea and we start insulin, generally we try and titrate them off that, because there's no real added value in having both the sulfonylurea and insulin. So we tend to try and get rid of that, and at least that means one less tablet that the person can take. And then we just titrate the insulin to accommodate that. And of course, these people will need reviewing and updating of their hypo-action plan. And because they're now on insulin, the complexity of their hypo-action plan does go up somewhat. So these are certainly patients where you will need the assistance of a diabetes educator. I love this slide. It's one of my favourite slides. So what you're seeing in the red is the insulin levels in someone. So you can see where the first spike is of insulin. That's been in response to the person eating, and then the insulin levels fall as the blood glucose falls. Then you can see another spike at lunchtime, and similarly it comes back down, and then the evening meal. So this person has clearly just had 3 meals in that 24-hour cycle. But the really interesting thing about this is that insulin never goes back to 0. So even overnight when the person's not eating, there's insulin on board. So you have to have insulin on board to be dealing with the glucose that comes from the liver overnight to be able to keep normal body functions running. So we always have to have insulin on board 24/7. So this is a very important thing to remember, particularly for anyone working in a hospital, because that's sometimes where people get into strife, is that their insulin gets ceased and then someone forgets to restart it or start a different insulin. And sometimes people will stop taking their insulin because they are not feeling very well, or they are not hungry. And so the education that these people are provided about their insulin is extremely important. So this is just a snapshot of some of the profiles that we see from the different insulins around. So you can see a single dose of rapid acting insulin or a long acting insulin. You can see the pre-mixed insulins with the first rise and then the longer rise from the long acting insulin that's in that. So you can see that we've got lots to choose from, and really the choice that is made is needs to be based on the person's blood glucose levels, so that we're matching the insulin to their blood glucose levels the best we can. So there's no magic bullet here, guys. We still have to do a thorough assessment of people's blood glucose, a thorough assessment of their eating patterns and the amounts of carbohydrate that they're eating, what their activity patterns are like, and using all of that, come up with an approach that's going to work for that person. So I'm hoping this slide might just help you understand the different groups of insulin. So I'm just going to start here in the corner. So basal insulin basal blood glucose. So remember that too. Insulin controls that baseline blood glucose, so that before the meal and in the morning, blood glucose is basically controlled at a fairly tight range. Generally, for most people with type 2 diabetes, between 6 and 8, and modified up for those people who are older or who have renal impairment or cardiovascular disease. But your basal insulin is your long-acting insulin that covers 24 hours, and it has nothing to do with food. So all it's controlling is your basal blood glucose. So if someone's on this insulin and they feel a bit sick and they're not eating, they still have their insulin because it does not control mealtime blood glucose. It only controls basal blood glucose. So that's very important when you're talking about sick day action plans, hyperglycemia action plans, hypo action plans. That topic is always discussed if someone's on this particular insulin. The green stuff down the bottom, we don't see very much anymore. So intermediate insulin, humulin N or protophane. And where we see this used most commonly these days is in gestational diabetes. So it actually works really well in gestational diabetes, and we also use it when people need to have an increase in their corticosteroids if they're having some acute issue with, say, their asthma or some respiratory disease. So if someone's having prednisolone, for example, in the morning, they've been started on 20 milligrams of prednisolone, you know, you've seen it 100 times, their blood glucose by lunchtime is through the roof. They've not done anything different. They've eaten the same, they've taken their normal medication, but their blood glucose is sky high. That's because the corticosteroids increase insulin resistance, and it specifically tracks along the course of the medication. So you'll get that increase around lunchtime and mid-afternoon, and then it will taper off at tea time. So we'll prescribe, generally it's protophane in SA Health because that's what's on the medication formulary, but we'll prescribe protophane in the morning. The profile of protophane matches prednisolone beautifully, and that will control the blood glucose throughout the day. And as the person is weaned off of their prednisolone, we just wean down the dose of the protophane, eventually back to 0, and then they go back on their usual medication. So gestational diabetes and for patients that are on corticosteroids, that's where you'll see protophane used the most. So both of those previous ones are called basal insulins or background insulins. Now we're going to talk about rapid acting insulin. So these are the insulins that deal with blood glucose related to a meal. So the patient will inject this insulin immediately before their meal, and as they're eating their food, their carbohydrate containing meal, the insulin's doing its job. It keeps the blood glucose from going too high after the meal, and we hope that then when the blood glucose is measured before the next meal, that it's back to its basal level. The blood glucose is back to its target basal level. If someone's sick and they don't eat, if they don't eat, they don't take this dose of insulin. This is where people can sometimes get into trouble with hypoglycemia if they haven't been explained to them properly that this is the insulin that you hold if you're not eating, but you continue to take your basal insulin because that one controls your basal blood glucose. So there's a few on the market now, and they are all sort of much the muchness. Fiasp is the newest one, and that's it's a bit faster acting than the other ones, but the Nova Rapid and the Apidra are probably the other two most common ones, and then Humalog we see very commonly used in insulin pumps for people with type 1 diabetes. Short-acting insulin, Act Rapid. The only place we see Act Rapid used these days is in insulin infusions in the inpatient setting. We don't use it in primary care. We don't use it in outpatients. It's not a great insulin to use in the community. It is a high risk of hypoglycemia because it's, although it's called a short-acting insulin, it's far from short. These are When we used to use this insulin, these were the patients that had to have their snacks, because if they didn't have a mid-morning snack, they would hypo before lunch. And similarly, if they didn't have a mid-afternoon snack, they would hypo before their evening meal. So we just simply don't use this in the primary care setting. Rapid acting premixes, so these are becoming, or the Novamix and the Humalog Mix 25 have been quite common insulins for a long time. The long-acting component of those two insulins is exactly the same as Protophane, so it does have a peak in it. So we do see some problems with blood glucose variability with these. The trick with a premix is that you really need to have a patient who has very regular meals, because there's a rapid acting component to this. And if you've got someone who has lunch today but doesn't have lunch tomorrow, or tea, or maybe I should say tea is a better example. They have a small tea last night, but then they have a really big evening meal tonight. Sometimes they have breakfast, sometimes they don't. This is not a good insulin for them. They need to have a certain amount of carbohydrate when they take this insulin because of the rapid acting insulin component. Otherwise, they will hypo. So it has to be taken with meals. So generally, if it's once a day, it's taken either at breakfast time or at the evening meal. If it is taken twice a day, it's then taken with breakfast or with the evening meal. It is never, ever given at bedtime. The little blue one down the bottom is very new, Ryzodeg. So the line covers that up a little bit, sorry, but that's Ryzodeg. So this is the newest premix on the market, and the beauty about this one is that the long-acting component of this premix is like it's like Lantus, but it's actually a little bit longer, so it lasts even a little bit longer. So the way this one works is that it's given with the largest meal. So if you've got someone who has a large meal at lunchtime and then always has trouble with his or her blood glucose before tea or into the evening, they can have this once a day at lunchtime, and the rapid acting component looks after their meal at lunchtime, and then they've got the long acting component that looks after their basal blood glucose. So it's quite a nice one. So it can be given either at breakfast or lunch or the evening meal. And the really good thing about this one too is that today I might take it at lunchtime because lunch is usually my biggest meal. But tomorrow I know that I've got family coming over for dinner, and so my lunch will be a bit smaller, but I know my evening meal is going to be quite big. So tomorrow I can actually take it at tea time. So because of the long-acting component and the way it overlaps, patients do have some wriggle room within that day. So they can shift from one meal to the next, but we do get them to blood glucose monitor just a little bit more during that time, just to make sure that if they do go a little bit low, they treat their hypo. And the very last little group down the bottom are the Mixitard and the Humulin 3070. Because these contain act rapid and not a rapid acting insulin, we don't use them in primary care anymore. I couldn't tell you the last time I saw these insulins prescribed because of the act rapid component of it just really isn't considered safe in a primary care setting or a community setting. So I would be very surprised if you've got any patients on these, but if you do, it's really important that they monitor their blood glucose and just be sure that if they are hypoing before meals, that they have a snack mid-meal prior to that meal. So they might have to look at some redistribution of their carbohydrate. And if they're not happy to shift to a rapid premix, then a referral to a dietitian would be really advisable, because we really need to make sure that we're protecting these people from hypoglycemia. This is just a little reference chart that I thought you guys might find interesting as a tool when you're back in your workplaces. So something to keep for you to refer to when you're talking to people about their insulins. So while I've got this one up, I'm just going to talk about Lantus. So you'll see Lantus listed at the top there on the right-hand side under basal background insulins. So Lantus, or Glargine is its chemical name. Lantus is its trade name. So the company that makes this insulin, for some reason, I don't know why, but they've decided to change the name of it. So Opticillin is the new name for Lantus. So it's exactly the same insulin. And so when your patients come in and they're on Lantus, generally on Lantus, it's a really good idea to just pre-warn them that at some point in the future they're going to be seeing a different insulin, an insulin called Opticillin, and it's exactly the same. Exactly the same. There is another Glargine U100 insulin that's on the market called Semglee, and that's very new as well. Now it's not identical. So Opticillin is identical to Lantus. Semglee is a biosimilar, and so hence the name similar, but not the same. So what the advice around that is that if someone's already on Lantus Glargine, switch them to Opticillin, not to Semglee, because you don't know if you're going to get the same effect from the Semglee as you will from Opticillin. If you're starting someone new on a Glargine U100, then you can pick and choose. But switching brands kind of midway, the advice from the endocrine units at the major hospitals has been try not to do that if you can. These are some images of some pens, and I thought that we might have a look at some pens, because all you've done is had to sit through these terrible PowerPoints, and you must be feeling a bit over it by now. So what I thought I would do is I've got a couple of pens that I want to show you, and the first ones I'm going to talk about are the disposable pens. So pretty well everyone makes a disposable pen now. So this, although we call it a pen, it doesn't look like a pen obviously, but it's got protophane in it, and they do make one which is a premix as well. And so for some patients that have dexterity problems, these aren't too bad. But like I said, they're limited to protophane and a rapid premix. So you still have to think about what the patient needs are and the best insulin for them. But these are still on the market. They're still quite popular with a lot of patients. There's a whole range of disposable pens. They all pretty well work exactly the same. So they're not difficult to teach. So there's a pre-filled chamber with 300 units of insulin. So all of them have 300 units. And it's easy enough to slide a pen needle, screw a pen needle on the end. Most people can cope with that. There are two caps on a pen needle. There's an outer cap. Patients can use this to remove the pen. Nurses never ever use these to remove pen needles. We don't remove pen needles at all. We give pens back to patients and they take the needle off. The risk of needle stick injury is way too great. So you'll notice, you might not be able to see that. It won't be able to see it unless I can't really get that to happen. But there's a 6mm needle. Now, one of the things that is really important when you're talking to someone about their insulin injections is what pen needle they are using, because you don't want them to swap and change between pen needle sizes. So this month they're using an 8mm pen needle. Next month they get given a 4mm pen needle. You're going to change the insulin absorption and you'll cause blood glucose variability. Decide with the person the size or the length of the needle that will work best for them and then stick to it. Don't swap and change in between. And really there's no clinical reason to have a pen needle greater than 6mm. So a 4, 5 or 6, depending on what the person's comfortable with. An 8mm pen needle you can still buy, and occasionally I come across a patient who absolutely insists on using one, and I will always teach them to do a pinch up, because you don't want the insulin to go too deep. You want it to go into the fatty layer under the skin. And so please, the pen needle is just as important as the device and the insulin that you choose in reducing blood glucose variability. So once you've got a pen needle on, with every injection, the person must prime the needle. Now, the main reason is to make sure the pen's working. And you know, I've had a sprinkling of patients over the years that have been dialing up their pen and injecting their insulin and hadn't noticed that the plunger wasn't going down and wondering why on earth their blood glucose was through the roof. Their pen was defective. So you always dial up a couple of units and press the end and make sure that there's insulin coming out the end of the needle. So check that with people every time you talk to someone about their insulin. Get them to get their pen out, get them to show you how they set it up, how they prime it, how they get ready to inject. So once it's primed and ready to go, dialing up the dose is the next step, and then deciding whereabouts on the abdomen the person's going to inject the insulin. Rotation of sites is critical. If someone continues to inject in the same spot over and over and over again, they will get hard lumps under their skin. And if they then inject into those lumps, they will change the absorption rate of the insulin and cause blood glucose variability. So rotation of sites is extremely important. And again, it's one of those things that you just have to keep reminding people over and over again, because people just slowly over time slip into the easiest way of getting the job done, and that's just human nature. So in a kind way, as nurses, we just encourage people and remind them of the technique. If you get a chance and you've got some privacy with someone, palpate their abdomen and feel for lumps and bumps, because they might not know they've got them. So if you can identify them early, then you can show people where they are and make sure then that they know that not to inject in those spots. So rotation is really important, and reminding people is really important. I can't underestimate the impact that you guys can have on those simple points in insulin technique. So then if they're using a relatively short needle, a 4 or a 5, they just inject at 90 degrees. I still get people to hold the pen like they are going to stab someone, and I always get a bit of a laugh out of that, because if you try and hold the pen like this and you're pressing with your finger, and you know someone's maybe on, I don't know, 60 units, you know, they're holding the pen and they've got the needle in, they're trying to push this, they don't have very strong hands, and it starts to wobble all over the place. Well, when it's wobbling, that needle under the skin is causing trauma. and it'll cause bleeding, it'll cause inflammation, and it will change the absorption of the insulin, and it will cause blood glucose variability. So I still get people to hold it like they're about to stab someone, and then they use their thumb, because the thumb is the strongest out of all the digits, and even the frailest of frail seem to be able to press the plunger with their thumb. And the other thing they can do is that when they put the needle in, they can use this part of their hand across their tummy to stabilise this, so that they don't get this wobble up when they press the plunger. So you will find that you will reduce blood glucose variability, and it will make a big difference. All of those little things, they all add up. So there are different pens. This is the one I really wanted to also let you know about. So this is Toujeo, which is the high strength Lantus. So this is staying on the market. It's still going to be called Toujeo. It's 300 units per 300 units per mil, sorry. So it's 3 times the strength of the usual Lantus. So what it means for people is they're injecting 1/3 of the volume. So what they get in 9 units of this, they can get in 3 units of this. So for those patients that are on really large doses of insulin, this is an absolute godsend for them. We've been able to stop people having to redial up and, do another injection. It's made a big difference to people. So that's one to look out for if you've got patients on very large doses. The other thing I wanted to, while we're on insulin, is to just remind you that there are insulin pens that aren't disposable, and a script of these pens is 5 in a box and 5 boxes. So you can imagine that's quite a bulky script. If you've got one of these, that's 5 of them in a box and 5 boxes. So the storage capacity for these is much better for people. We've stopped giving people a choice, and I'm a bit worried about that, because I'm coming across patients that didn't even know that they could have a pen that they could put a cartridge in and use the cartridge, and then take the cartridge out and just have that as a throwaway rather than that. So for people who are a bit keen on saving the planet, we're finding that they quite like the idea of having a pen device. We've kind of slipped into the GPs just straight up writing a script for a disposable pen, and we're not even giving patients a choice of not having a disposable pen and having a rechargeable, reloadable pen device. Now those devices, if you see a diabetes educator, they are free. We get given them by the companies. If you go to Diabetes Australia, you'll have to pay for it, but if you refer your patient to a diabetes educator, we can give them to them for free. So if you're happy to talk to your patients about the options that are available for them, I think that would be fantastic. The other 2 devices that I'll very quickly show you, and you may have already seen these. So remember the GLP-1 injections I was talking about? Well, this is one that is one of the weekly injections. This one hides the needle inside. So if you've got someone who's a bit needle phobic, this is a fantastic device to use if the doctor thinks that this medication will work for the person. So basically they get 4 of these for a month. It's quite a bit of plastic, I know. You take the plastic cap off, you unlock the pen, and you put it on the person's tummy. It doesn't have a needle in it, don't worry. And you push the button down and you wait for a second click. Second click. I'm not going to get a second click. That's all right. It's an education pen, so it's probably worn itself out. But you get a second click, and that lets, oh, there it goes. And that lets the person know that it's all been injected and they can take this off. That then needs to go in a sharps container because it does have a sharp in it, even though it's a bit big. So there are different devices for different medications, injectable medications, whether that's a GLP-1 or an insulin. And if you want to learn more about those, please contact your local diabetes educator, because we would be more than happy to be able to do some work with you around that. Okay, so we've got some questions. My goodness. Okay. Good question. Heath has asked, does the same needle stay on the pen until it is empty? No, 1,000 times no. People do that, and they end up with nasty sores on their tummy. The injection hurts because each time they put the needle in, it scratches the skin as it passes. The needles are actually designed to be single use, and they are free. So there's no excuse for someone not putting a new needle on every time. So when I teach someone to self-inject, we start with the pen without the needle on it, and we finished with the person taking the needle off and putting it in a sharps container. So that becomes part of the whole process. So yeah, Heath, encourage your patients to change their needles. So registered with the NDSS, pen needles are free. They don't have to pay for them. They just order them through their local pharmacy. Then, hi, if a new patient diagnosed with type 2 would like to life control his blood glucose levels, the doctor says patient to record their daily glucose levels every pre and 2 hours after meals for a certain period before going on to any medical treatment. Patient often do exercises after meal, and most 2 hours after meal data sit within normal range, which is good that patients understand the importance of doing exercise. However, are those after meals data correct or objective for the, yeah, okay, so it's anonymous, the question. So if I'm interpreting it correctly, the question relates to postprandial blood glucose testing. And 2 hour postprandial testing in type 2 diabetes is not as useful as it is in type 1 diabetes, particularly if they're not on rapid-acting insulin. Once they're on rapid-acting insulin, then 2 hour postprandials become really important. But generally, pre-meal, so fasting, pre-lunch, pre-evening meal, and before bed gives you your basal blood glucose readings. And if they are under control and your HbA1c is okay, then there's no reason to go looking 2 hours postprandial. However, if you've got someone who their basal blood glucose looks fine, but their HbA1c is high, then you know that there are high readings hidden somewhere in the day. And that's when I would go looking for post-meal hyperglycemia. But generally, if the blood glucose is down before the next meal or before bed, if we're talking about the evening meal, and HbA1c is fine, then I do not badger people to do postprandial testing. Diabetes is hard enough without us making people do stuff that doesn't really give us any more information. Doing fasting and preprandial and HbA1c initially gives us plenty of data to be able to assess someone's diabetes status and how they're progressing. How do they work out if patients need to protocol doctors send them out? Yep. So Rochelle has asked me, how do they work out if a patient needs a GLP-1 or not? Is it standard protocol after having diabetes for a certain amount of time, or do their HbA1c levels need to continue to be high? So we would look at commencing another medication if the blood glucose is progressively getting higher. So they're outside the target ranges that have been set for that person. The choice of a GLP-1 compared to, say, an SGLT2 is about blood glucose. Where's the blood glucose problem? So with a SGLT2, for example, the one that makes you pee more glucose, if the blood glucose is generally up right across the day, then the SGLT2 is a really good choice, because that helps control blood glucose right across the 24 hours. If it's a mealtime issue, so it's related to carbohydrate intake, then a GLP-1 or a DPP-4 would be worth, considering, because we know that when there's carbohydrate in the gut, the GLP-1 or the DPP-4 will work on that, and so it's particularly good at meal times. So those are the sort of things that we assess and talk to the patient about to be able to determine, well, okay, you're on metformin, your blood glucose is starting to climb, we've gone through all the lifestyle stuff, you're doing all the things that you can do within your own capacity. We need to think about the next step in medication. Those are the things that we would be considering when we choose a medication. I've come across quite a few patients who actually get denial. Yeah, so Lynn has raised the question about patients who actively deny that they have diabetes, and have told her that the doctors told me I don't have diabetes, but when she's looked at the results, clearly the person does have diabetes. That's a really tricky question. If the doctor doesn't diagnose diabetes, then that puts you in a really difficult position. I think if you were to just encourage the person around lifestyle factors, I mean, obviously the person's not home blood glucose monitoring because they wouldn't have access to that unless they'd had a diabetes diagnosis, but by the look of it, blood results have shown that. So it is a really tricky one. I feel for you in that situation. I think unfortunately you have to work within the confines of the team that you're working. I would just encourage the person to talk to the doctor, and maybe even if you were able to raise with the doctor that you've noticed these blood results are in the diabetic range, yet the patient, when I talked to the patient, they told me that they don't have diabetes, that you said that they didn't have diabetes, and I just, can you explain to me the thinking behind that, which would be a very reasonable question. If an elderly person needs insulin later in life, needing due to illness, what's the likelihood that they may be able to get off insulin? Okay, so the question from Monica is about if an older person required insulin later in life because they were unwell, and whether they might be able to get off it. So I think an example that comes to mind would be if an older person, say, is admitted to hospital with pneumonia, and they are and their blood glucose levels rise, it would be fairly common to use insulin to control their blood glucose while they're in hospital. But in a lot of cases, as the infection subsides, as the insulin resistance comes back to its sort of pre-illness level, in most cases people can go back to the medication they were on before they got sick. However, if their blood glucose was out of control before they got sick, then sometimes they will stay on insulin when they are discharged. So it just really depends on how well they were controlled before they became unwell. When insulin pumps are used, is it usually a short-acting insulin? Yes. So the question is, Lisa's asked, with insulin pumps, is it usually a short-acting insulin, basal insulin, or a mixture of both? It's actually rapid-acting insulin that's used, and the two insulins that are approved in Australia for use in an insulin pump is Nova Rapid and Haemoglobin. Fiasp and Apidra aren't actually approved for use in pumps. However, we do know of patients that use them in pumps. I might have to, what's the time? Oh, it's way over time. Oh my goodness. I'm so sorry, guys. I'll do one more question and then I am going to have to, I'm going to have to stop. Patient I looked after was on Lantus and Apidra but was replaced by Risodeg, which is a combination of rapid and slow. Yes, so Rochelle has asked about a patient that was on Lantus and Apidra and then was switched to Risodeg, which is, yes, you're right, is a combination of rapid and slow or long-acting insulin, very long-acting insulin. It'd be interesting to know how well the patient's going, because if they were requiring Apidra for all 3 meals and now they're only getting rapid-acting insulin with 1 meal, then they might not be doing very well. It's unusual to go from basal bolus, which is basal insulin, and then your 3 doses of rapid-acting insulin with meals. It's unusual to go from that to a premix. That's kind of going backwards. So it would be interesting to know how the patient is faring on that. What can I suggest? Well, I would need to see, so Rochelle's posted a follow-up question to that about what I could suggest, and I wouldn't be able to suggest anything until I saw the blood glucose results and a bit about their medical history. So generally, once people are on a basal bolus insulin schedule, generally they stay on it because they've gone on it because they need mealtime help and they need basal blood glucose help. And I think I'm going to have to finish up, guys, because otherwise you're not going to get to bed.
Great, so that was the last question, everybody, and thank you, Jane. Would you like to add any final remarks before we conclude?
I guess thank you for sticking with us tonight. I'm sorry I've gone over time. Don't be frightened to learn more about the medications. To ask your patients about how they're coping with their medications, what questions they might have. If they come up with questions that you feel worried or uneasy to answer, please contact your local diabetes educator. We're more than happy to support you in the work that you're doing because we know it's a big job. We know that it's a big job out there. So please think of us as colleagues and people that you can use in your network to support the work that you do, because we think you're all amazing.
Thank you very much, Jane. Before we close, we'd like to remind participants about Health Pathways. This is a web-based information portal supporting primary care clinicians to plan patient care through primary, community and secondary healthcare systems within South Australia. To find out how to register, visit saproject.healthpathwayscommunity.org. We have included a link in the chat function, and that concludes tonight's session. Thank you to Jane for this very informative education session, and we hope everybody found it as valuable and relevant to your practice. SAPMEA would like to recognise and express gratitude to Country SAPHN for funding this valuable education learning session. When you leave this webinar, you will be prompted to complete a brief evaluation. So please take the time to complete the evaluation, as your responses will help us improve future education sessions. Don't forget to visit our website for all upcoming CPD activities. Thank you everybody for your attendance and have a good night.